Hello, it's Beth Wright, and I'm providing you a podcast for Chapter 3, Unit 2 of your Nursing Pharmacology 136 class. So, again, be sure to look at your objectives of your syllabus for Unit 2. Okay, so I want to start off with going over the nursing process because this is what this chapter is all about. And the nursing process is what we're all about as nurses. It's one of my favorite things to talk about. And I want you to just, sit back a minute and think about what this is, what the nursing process is. Because again, it's what we're all about. And it's kind of like riding a bicycle. Once you learn to ride a bicycle, you always know how to ride a bicycle. And the same being true about the nursing process. And so it is a systematic way of gathering and using information to plan and provide individualized patient care. You definitely need to know that definition, okay? So a systematic way, meaning it's got steps and it's got a process that we go through. And we gather information and use information from the patient. We gather information from the medical record. We gather information from laboratory values, x-rays, things like that, and use that information to plan and provide individualized care. So here are our steps that are involved in this. We have the assessment, which is where we collect patient information that affects drug therapy. And we're talking about drug therapy because we're in pharmacology. But the nursing process is something you're going to use for everything you do with the patient. Okay? So we first do that assessment, and that's where we're going to check the patient out. We're going to ask them questions. We're going to listen with a stethoscope to their heart and lungs and bowel sounds. We're going to take their blood pressure, pulse, temperature. We're going to talk to family when it's applicable or a significant other. We're going to look at lab work. We're going to look at radiology results, things like that. So that's where basically we're going to collect information about the patient, both by the patient and our family, and different records that are indicated. And then we have we formulate, based on that assessment, we formulate a nursing diagnosis. Now, nursing diagnosis is basically a specific problem that we derived from the assessment that we've done on the patient. It's not a medical diagnosis at all, like heart attack or hypertension. We have our own special list of diagnoses that we use. For the most part, with pharmacology, we're going to work with specific ones, such as risk for injury related to adverse effects of medications, knowledge deficit related to drug therapy. It could be, how the medication is administered for the patient that they don't know, so we're going to teach them about that. It could be that they don't know what the therapeutic effects should be, or routine testing that's needed. So we will use pretty much specific nursing diagnoses for pharmacology, but there are a slew of them that you'll learn about when we're working with patients. The next step in the process is our planning, or basically our goals, and these are expected outcomes of prescribed drugs and nursing care. And so, we use the nursing diagnosis of at risk for injury related to adverse effects. Well, our goal is going to be we don't want any adverse effects, if at all possible. If we can avoid them, we definitely want to try to avoid them. So goals are going to be established with the patient. Otherwise, it's not going to do us any good to go out there and work on something all of our own. So we've got to be working with the patient here, and we've got to, it's got to be an individualized plan of care. So the next step is our interventions, and this is what we do. This is our actions based on what the nursing diagnosis and the goals are. And these can be numerous things. This is where we use our evidence-based practice to know what to do. We don't try to do things with patients that don't have some type of evidence that shows it's the right way to do it. So it's very important with medication therapy, especially. And so, we know with medication, and drugs and things, as there has been a lot of evidence-based research done on these medications even before they hit the market to be used. So, we know, I'll give you an example, like we know that blood pressure medicines can sometimes cause patients to have a condition such as orthostatic hypotension. Orthostatic hypotension means when that person changes positions, from lying to sitting or sitting to standing, their blood pressure drops significantly. And when that happens, they can fall. And they are definitely at risk for injury there. They can become dizzy. So we have to teach the patient about that. Our goal in that is going to be that we have no injuries related to falls because of the orthostatic hypotension. So we're going to teach the patient to rise slowly, to change position slowly. So you'll see evidence-based information in your textbook. As you start studying about the drugs, that's what you're seeing is in, evidence-based practice. Now, be sure to use a good source of information here when we're working with our patients. Sometimes people Google things and they come up with stuff that's not accurate, and so, we talked about that in Chapter 1, so, just remember that. The next and final stage of the nursing process is evaluation, and this is determining a patient's status in relation to the stated goal and the expected outcomes and the intervention. So we evaluate, did we meet our goal? And we evaluate each of our interventions that we do. Because we got to do that. We want to make sure what we did worked, and if it didn't, we need to go back and punt, so to speak. So when you look at this whole nursing process, it's a continuous process that we do, and you will learn by the time you finish school, or hopefully by the time of the end of next year, you're going to walk into a client's room, and that nursing process is going to start. And you're going to notice things. You're going to start assessing immediately. You're going to pick up on things like, oh my gosh, their skin color looks terrible. Our nursing diagnosis may be that we're having an oxygenation problem or some kind of problem. And our goal is going to be get on top of that immediately, dealing with maybe our airway, breathing, circulation. Our interventions are going to start working on those problems immediately, and then we're going to evaluate, is this working? Because if it's not working, we can't just sit there on somebody's color turning blue. We got to move on that. So you'll start slowly with this whole nursing process, but I want to introduce it to you now because it is what we're all about. And I want you to start utilizing it here in this class. Okay, so we've already kind of talked about the rights of medication administration, but again, we got to think about, and this, when we're dealing with medications, these are what we want to get 100% of the time, okay? So let's talk about how we get these. So the right drug. How do we know we have the right drug? Of course, we're looking at it. We want to look at the healthcare provider's order because that's what, we're going on there. We want to check the medical record, the chart, and then we check the medicine. Now, if we go in, let's say that you're doing this, you're there giving medicines and you're trying to make sure that you have the right drug, okay? And something in your gut just saying, this isn't right. Something's not right here. This does not, for instance, let's say that you have a chemotherapy drug for cancer that's ordered for your patient. It's in the chart. It's in the medication drawer. It's there. You're looking at it. But you don't know of any indication for this medication. So, what must you do when that happens? You must take that further. You must investigate. You must call the doctor and say, Doc, this medicine's ordered and it's for da 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 da. And he's gonna or she's gonna say, uh-oh, I wrote that on the wrong patient. Okay? So you are the last defense before the patient gets the medicine. If you feel that you have the wrong drug, then you must take it further. That's being accountable. That is being your patient advocate. That's doing the right thing. Okay? I'll give you another example. The right drug. Okay, so you're in a patient's room and you're preparing his meds and you're telling him, what your meds are, and he's like, hey, wait a minute, I don't, that's not, I've never been on that medicine. Is that something new the doctor's ordered? Don't just say, yeah, probably. You say, okay, let me stop right here and we're going to confirm that. Because once again, mistakes happen all the time, guys, and we are that last defense. So can't tell you how many times the patients have said something to me and it's caused me to stop what I'm doing and go to the chart and look it up to make sure that in fact has been ordered. And the patients, you have to listen to the patients. They know best about their bodies and they know their regimen and all that the best. So listen to your patients. So many times you see this not happening, and we've got to. Okay, right dose, kind of the same thing. Now, with both the right drug, right dose, route, the right route, right time, all of that. This means that you've got to spend time looking up your medicines. Now there's a boatload of medicines out there, boatload, but what you're going to need to do. You're going to look up these medicines in a reliable source and make sure that you have the right drug, that you have the right dose. I mean, again, mistakes happen. And so if the dose seems excessive, ask about it. Find out about it. If your patient says, wait a minute, that pill does not look like the one I've taken, at home, for instance, find out about it. Investigate it. Okay? And let's say the patient says, wait a minute, you're giving that to me the wrong way, meaning the right route. Okay? That's, you've got to make sure you can give, certain medicines are out there and they cannot be given through an IV. There are certain medications that are intended solely for IM injection. There are medicines out there that when you're talking about the route, there's certain medicines that cannot be given, let's say subcutaneously. Okay, so you've got to know this, and the way you're going to learn this is by looking up the medicines. Now, each of the facilities that we I'll do clinicals at will have access to drug information while you're doing clinicals. So it's going to be really important that you look up these meds, okay? And that's a way you'll learn about them too. All right, right patient. Let's talk about that. The way we do that, we go in and we say to the patient, tell me your name and your birthday, and then you're going to have a record there to make sure that those match what the patient tells you. So that's our right patient, and you always want to do that. Again, the right time. What time was the medicine ordered? What's the schedule of the medicine? You know, is it every 6 hours? Is it every 12 hours? Is it every 8 hours? Is it twice a day? So the right time is very important, because many medicines, they have to build up in your body and maintain a certain level in your bloodstream to be able to finally work. And so the right time deals with that, okay? So again, you'll see this when you look up your medicines. The right reason is, what's the purpose of the medicine, okay? What's the indication for the medicine, and does that match what the patient has? Now, sometimes you're going to see medicines, a Neurontin, gabapentin is a common one here, or a one that is actually, it was developed for anti-seizures, to help with seizure medicine or help seizure patients, but they discovered that it helps with peripheral neuropathy, like what diabetics have, pain in their feet, and so it also helps with like neuropathy that's related to back injury. So that's something that you know, you may see from time to time, that there's other indications that for medications, and again, you'll see that in the evidence-based literature that you read on the medications. When it doesn't match, we've got to investigate it. We don't just go ahead and give that medicine to the patient. When we have a conflict here, you got to do it. You got to look it up. Again, that patient's counting on you to do that. And then, of course, right documentation, and that is done differently in different hospital settings. In a nursing home setting, you're probably going to have a written record where you know, do your written documentation. In the computer, in the hospital setting, most of these have computers, and they have computer-generated medication administration records. And as we do scanning with the patient, and we are in there under our system, then it documents for us as when we give the medication. So the right documentation has to take place. And, you know, that means if a patient says, no, I don't want to take that medicine, it makes me feel funny, then you've got to document patient refused medication, states makes it feel funny. You also got to let the doctor know. You got to let the healthcare provider know about that. So the right documentation is documenting exactly what's happened, and, you know, following up on any concerns. So, accurate drug administration principles, we follow those rights consistently, and we learn the essential information about the medications. So, we're talking about what the medications are indicated for, what's the contraindications, what are therapeutic effects, and let me just mention what's contraindications. So, contraindication means we don't give it if there are contraindications. So sometimes for every drug, you'll see, are they, if the patient is allergic to the medicine, or hypersensitivity, it'll say, then we don't give it. So contraindication means don't give, okay? And, you know, you'll see various things like, if they're allergic to it, if they have any kind of kidney problems or liver problems, for many medications they can't take it, so you may see that as well. Therapeutic effects, what's expected. And that's going to be, you know, okay, so we're giving the blood pressure medicine to a patient, an antihypertensive medicine to a patient with hypertension. We expect to see the blood pressure to be within normal limits. So, you know, we got to know the indication to know the therapeutic effects. Adverse effects are what's, you know, the side effects. What's adverse here when we give this medication? And let me tell you, you're going to see a slew of them. And I've said it before, I don't know why anybody would take any medicine after they read those side effects. But people do. People take a lot of medicine. So adverse effects, we need to know, because we need to know what to expect if something goes haywire on us. We also, you know, need to look at those adverse effects. So let's say that we're given an antihypertensive and we know that that's going to lower the blood pressure. Okay. An adverse effect is that it can cause hypotension. So we need to check that blood pressure before we give it to the patient to make sure their pressure isn't already too low. Okay? Because if we give it to somebody whose blood pressure is already too low, then it's going to lower it even further. So adverse effects are going to be very important. And then specific instructions, that's going to be, you know, the teaching that we do. And we do a tremendous amount of teaching. So we, you know, just some examples. We teach patients if there's any medicines that causes a depression of the central nervous system, then we tell people don't drive or operate heavy machinery until you know what this drug, how it affects you. Don't drink alcohol with specific drugs. Sun sensitivity. Some medicines, antibiotics are a few of them that cause sun, increases the sensitivity of the sun. And so people can absolutely get blistered in the sun when they're taking certain medicines. So we have to tell patients about that. So every drug's going to have teaching opportunities with it, and that needs to be shared with your patient. Okay. Interpreting the prescriber's orders accurately. Drug name, dose, frequency, and route. If you can't read it, don't administer it. And we got to communicate with that prescriber. Also, we got to read the medication labels carefully. I've got some examples there where you can see Lipitor 10 milligrams, Prevacol 40 milligrams, Zocor 10 milligrams. Those are PO medicines, oral medicines like tablets. On your right side, you have a vial of medication. And that's, if you can see there, it's 10 milligrams per milliliter. And there's 10 milliliters in the vial there. So that's going to be like a multi-dose vial that you'll use. That has to be labeled and initialed when, dated and initialed when it's first used. And there's time limits on how long a multi-dose can be used. But we have to be very careful about, you know, if we, so take a look at that methylene blue. So the order is, let's say, 10 milligrams per ml, but the nurse draws up 10 mLs. How much is the patient going to get? OMG. You know, again, see how easy that kind of thing can happen. So safety, 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 safety. That's always the number one thing as far as medication administration and preventing errors and preventing injury. Other things we do: minimize abbreviation use to prevent errors, and so the Joint Commission has a do not use list. You need to be sure to take a look at that. We need to be sure to calculate the dose accurately, and that's crucial. And then measuring doses accurately. There's a standard of care now, and we have to have 2 licensed people to double check high risk medications such as insulin and heparin because of serious injuries that have occurred to patients. Okay, use correct procedures and techniques for all administration routes. So oral, IV, IM, sub-Q or subcutaneous, rectal, vaginal, eyes, ears, topical. Okay, so the procedure for administration is going to be extremely important. And learn about the patient's diagnosis and conditions in relation to medication administration. So, for instance, when we're given oral medicines, does the patient have any trouble swallowing? If they do, then we may have trouble getting those medications down. And so they may need to be looked at and ordered in a different route if it's available. Allergies, we need to always look at our patient allergies and those contraindications that I talked to you about earlier. We're always going to verify the patient ID. Any omission or delay as indicated by the patient's condition, or omission or delay in the doses because of a patient's condition must be documented, and we need to communicate that to the healthcare provider. So let's go back to the patient who's on an antihypertensive for high blood pressure. Okay, we take that blood pressure and it's low before we are given the medicine. And so we're like, no, we don't need to give this because it's too low. It's going to cause them to bottom out, to have a lower, a really low blood pressure. And so you would want to call the doctor about that you've held that medication, you've delayed it because of the pressure. Okay. Now, just a word about that. You will probably get this saying from the doctor: have you checked the blood pressure manual? Because we have automatic blood pressure, automatic machines that check the blood pressure. Always, you want to do your homework before you call your doctor or your prescriber. And you'll learn about that. We have a form called the SBAR where it takes you through the situation, the background, the assessment, and recommendation before you call a provider about anything. But anyway, there are times where we're going to omit or delay doses based on what's going on with the patient. That's got to be dealt with, addressed, okay? And children, be extremely careful when we're dealing with children because of high-risk medication errors due to dosage changes and that kind of thing. Now this is one of your pictograms, and it's really busy, isn't it? It's talking about on your left side, the R's, or your rights there. If you start up at the top, the methods, we got the oral. Again, is the patient able to follow directions, or are they able to swallow? You've got your topicals, and that is topicals are given rectal, sublingual, nasal, in the eyes, the ears are on the skin. Then on the other side, you have an IV, and it goes into the blood. And a large volume medication, and it can be irritating to the vein. Intradermal is just below the skin, and that's we can do TB testing. Y'all know about that already, or will know about it. Your local anesthetics can be done that way, like if somebody's got a laceration and they got to have stitches, then they will do local anesthetics that way. Or allergy testing is done that way as well. And then we also have the IM injections, and that goes into the muscle, intramuscular. That's what that stands for. And it shows you the little X's there where you can do that. And then we have the sub-Q or subcutaneous. That's a small amount, and it goes into the subcutaneous tissue. Talks about the Z-Track method. That is looking at IM injections to prevent leakage and staining of tissue. And then we have inhalation medicines, solids, and transdermals. Those are solutions. The inhalation is a meter dose inhaler, MDI. You may have a powder, or you may have a nebulizer. You may have solids, capsules, pills, tablets. You may have suppositories, or you may have ointments and that kind of thing. And then we have transdermal, which is things that are placed on top of the skin, like a patch, for instance. So that's your forms. And then you have nursing responsibilities. So we only administer meds that you prepare only. Don't ever take medications from someone and give them. You need to be the one to prepare them. Got to be familiar with the med, know the indication, side effects, dosage, and safety precautions. We got to document. We got to evaluate the client for therapeutic effects and adverse effects. Don't forget about aseptic technique. That is a sterile or as clean as can be procedure. No medications are stored at the bedside because you never know who could take those. And review med administration if client is to do by himself. And of course that's going to be teaching. Okay, so I got a sample question for you. The prescriber has written a medication order that the nurse thinks the dosage is excessive. Which of the following actions should the nurse take? So let's think about it and what we've already talked about. First off, we don't want to do that because, again, if we have a feeling that something's up with this, that there's a problem, then we've got to address it. We are that last defense. So A is no. How about B? Ask the patient about allergies. Okay. So allergies and dosage really do not mix. We are going to ask the patients about allergies, but not with respect to thinking that the dose is too high. C, ask another nurse to look at the order. Okay. I mean, you can do that, but is it going to take care of the problem? And D, review resource information about the drug. Okay. Yeah. First off, we got to know for sure that the dose is high. The nurse thinks the dose is excessive, but do we know that for sure? So we got to review the resource, and then if we still think that it's too high, then we're going to call that prescriber. Okay, medication errors. They can result in death, bottom line, but serious illnesses, conditions that prolong hospitalization or require additional treatment. And they're very, very serious. And like the bottom line is it can cause death. So we want to do everything in our power to prevent that. May occur during manufacturing, prescription, transcription, dispensing, and administration. So, as you know, manufacturing is going to be your drug company. Prescribing is going to be the healthcare provider that's licensed to do so. Transcribing can be the healthcare provider, or that can actually be a nurse as well. Transcribing means writing, actually. Dispensing is going to be your pharmacist, and administration is going to be your nurse. Okay, so there's it's a complicated process when you're thinking about the whole process of medications and how they get to patients, especially in the hospital setting. Common medication errors include giving an incorrect dose, the incorrect route, or incorrect frequency. Not giving an ordered medication, which is called omission or omitting. Giving an unordered medication. Um, Medications often associated with errors include insulin, heparin, warfarin. These are very high risk medications, and they many times include. So I've got a video that I'm going to attempt to show you. It's not very long, so let me see if I can get this to work.
It was November 2007, less than 2 weeks after Dennis Quaid's twins were born, when the actor says the nurse caring for them nearly killed them. The babies, Thomas Boone and Zoe Grace, had been readmitted to Cedars-Sinai Hospital in Los Angeles for a staph infection. But the nurse unknowingly gave the twins 1,000 times the recommended dose of the drug heparin, a blood thinner. Quaid and his wife were in the room, but didn't know anything was wrong until the next day, when they found their newborn twins bleeding profusely.
Their now water-thin blood had the real possibility of hemorrhaging through a vein or artery, causing massive brain damage or failure to one of their vital organs.
Quaid says the twins were supposed to receive 10 units of heparin, but instead got the adult dosage of 10,000 units, a massive overdose that turned their blood thin as water. How could this happen? Quaid says both the pediatric dose and the adult dose of heparin have similar labels. For the next 41 hours, doctors scrambled to save his children.
At one point, as the doctors tried to clamp a bleeding wound in the remnant of T-Boone's umbilical cord, blood spurted 6 feet across the room and splattered on the wall.
It was the most frightening night of his life. They'd worked so hard to have children. First, trouble conceiving, then miscarriages, and now this.
Our babies could have died that night.
3 other babies did die in Indianapolis a year before. Just like the Quaids, the 6 infants in that case were given adult doses of heparin. Half of them died.
They recall automobiles, they recall toasters, they even recall dog food. But Baxter failed to recall a medication that, due to its labeling, had already killed 3 infants.
Baxter International, one heparin manufacturer, told CNN it had redesigned the drug's vial before the Quaid scare to help doctors identify the right dosage. But Baxter did not recall the older vials, so they were still being used at Cedars-Sinai, where Quaid's children were treated. Quaid sued Baxter for negligence, but the case was dismissed. Quaid and his wife reportedly settled with Cedars-Sinai Hospital for $750,000. But they say this isn't about the money. This is about protecting patients and doing something about the nearly 200,000 Americans who reportedly die each year due to medical errors. Randy Kay, CNN, New York.
Okay, medication systems. We have, various types out there. There's unit dose systems, where, if you've got a 10 milligram of a certain medication given, then that's what you're going to be provided with. So it's a unit dose based on unit dose. We have computerized locked cabinets. We have security for controlled substances. We have floor stock that's available to provide given medications that are frequently administered. We have a crash cart that provides medications in an emergency situation that are frequently given. And we have procedure carts that, if a doctor's doing a procedure on the floor where you're at, they'll sometimes have medications in that that they'll need. Computerized provider order entry is a great thing that most of our area hospitals have gone to now. and that's meaning that the doctor or healthcare provider enters their orders into a computer system to prevent them from having to write orders. I'll give you an example of a written order here in a minute that is very hard to read. Barcoding is something else that's done. So each of the medicines, and you see the barcode on this part right here. Again, I don't know if you've seen it, but you all know what that is because of the grocery store. So the patient will have an ID band that has a barcode, and the medicines have a barcode, and these have to match. If they don't match, the computer will let you know, and you don't give it until it is investigated and resolved. Again, Joint Commission, do not use lists. We got to limit abbreviations and medication reconciliation. So what that is let's just walk a patient through. So the patient comes into the hospital. We need to see what medications they are on in their home setting. And we prefer to see the actual medicines, if at all possible. Then we compare that list with what the medicines prescribed for the patient when they're admitted to the hospital. Okay, then we take care of any kind of discrepancy. Okay, let's say that the patient has to go to surgery. Again, that medication list needs to be looked at, and based on what's going on with them in surgery and what's going on with them on the floor. So medication reconciliation should occur anytime the patient's admitted, anytime the patient's discharged, and anytime there's a change of service within their admission time frame. And that is so that we will prevent any kind of unnecessary meds being given, or will not omit necessary medications that should be given. Okay, medication orders must include the patient's name, the name of the medications. You may see brand or you may see generic. Dose, route, frequency of administration, the date, the time, and signature of the prescriber. So here's an example of an order. And I've been around doctors' writings for a long time. I cannot make out that first one, except it looks like 40 milligrams. I wouldn't swear to that. I can tell the PO, and that's going to be by mouth, and then times 1, and that should be, I think, stat, which means immediately. Not sure about the second thing. Not sure about the third thing. The fourth thing, whatever it is, I'm not sure, but it's Q4H. I'm going to guess that's albuterol. So again, we should not have to be guessing. Okay, you can't make this out. The doc's going to have to be called on this. No question about it. Okay, transcription of medication orders. So they're typed into the computer, and that's the preferred method. They can be handwritten on an order sheet. Now, if it's after hours and the healthcare provider is not there, then we have to call them at home, and we'll take what we call a verbal/telephone order. So again, we got to make sure we got the patient's full name, the right patient. We listen to what the order is and write it out, and then we read back the order. And you got to have your drug name, your drug dose, your drug frequency, your drug route. Okay, the transcriber signs it, and then the prescriber signs it within a 24-hour period. Okay, and that is a law. That's the rules. You got to read back those orders and document that you read back the orders as well. Carrying out the medication order in a hospital setting, and it can be in a nursing home as well. The orders are written or entered in to the computer. If they're in the computer, then they're going to go straight to pharmacy. If they are if they're written, then we'll fax those to pharmacy. Pharmacy fills the orders and dispenses the medications, and then the medication administration record is prepared. Sometimes by nursing, sometimes by pharmacy. This is an example of a written medication record, and some of the computer generated ones look like this as well. So you'll see you got an area for your patient's name and all of that. And then you have allergies, you have diagnoses up there. The verified at the top left hand means that the nurse has double checked that to verify that all those orders have been in fact ordered. And so you have the start date of when the medicine was ordered and the stop date. If there is an automatic stop date on the medication, sometimes medicines have to be reordered. And so then you have your medication name, and notice that it's got your name, dosage, how often it's given, and it also has the PO for by mouth, so it's got your route in there as well. And then it gives you a time on the right hand side, 0800 to 1559. So this is the time that you document that you give the medication. PRN medicines are as needed medications that are ordered. So if somebody has a temperature, they've got ordered acetaminophen, or if they've got pain, they've got acetaminophen ordered there, PRN. And then at the bottom of the page is where initials and signature has to be provided. And it gives you a little key that you can use for sites of where you give medicines and codes as well. Okay, which of the following is the preferred method of order transcriptions? So is it telephone, a verbal, handwritten, or computer entry? Okay, hopefully you said order entry, because that's what we want to do. All right, so medication order interpretation. So nurses must know commonly used abbreviations, and that's on page 43. So take a look at those. And we also have other ones. The Q means every, so Q6H, Q8H, Q12. TID is 3 times a day, BID is twice a day, and QID is 4 times a day. So routes and a lot of times are abbreviated as well, and times of administration are abbreviated. Remember to look at your do not use abbreviations, and illegible, seemingly erroneous orders must be clarified before we administer. Okay, here's some more abbreviations as far as routes. So IM is in the muscle, IV is intravenous, PO is by mouth or oral, SL is sublingual, and sub-Q is subcutaneous. And then here are some of our dosages. Although CC, they don't recommend that you use that abbreviation anymore. Some of these actually may be on the do not use list. And then here are some others. Ad lib is as desired. PRN is as needed. Q4H is every 4 hours. And STAT means immediately. Okay, so here are other terminologies that are medical terminologies with MedAdmin. We have units such as insulin or heparin. They're given in units. GI would be G-tube. G-tube stands for gastrostomy tube. J-tube stands for jejunostomy tube, and NG stands for nasal gastric tube. Extended release, you'll see that with XL, sustained release, SR, long acting, LA. And these are the medicines that you cannot crush to give it to someone who's having trouble swallowing. Metered dose inhaler, initials are MDI for that. Lozenges or, like Hall's cough drop or whatever. Enemas are medicines given rectally or vaginally. Intravenous piggyback is IVPB. So that's piggyback means it's a little smaller bag of medicine that's given in a shorter amount of time, and I'll show you a picture here in a minute. Expiration date, we got to be sure to look at expiration dates on medicines because they do expire, and if we find something expired, we should not be giving it. Compatibility, very, very important as far as any IV medications. If you're giving IV piggyback medications and you need to give another type of IV, you got to be sure that these medicines are compatible before you give them together. Very, very important. So sometimes medicines do not mix, and so you got to be sure to look for that. Ophthalmic is going to be medicines that are given in the eyes, and otic is medications given in the ears. Medications may be available in various forms, so definitely see that. And so we got to do what's best for the patient. If liquids work best, or tablets, capsules, suppositories, or transdermal, that kind of thing, we would want to see that provided. Okay, so these medications are examples of different types. You see the tablets starting on the left side, and they look a little bit as you move on down the third one, fourth one, they look like those may be enteric coated, and maybe even the second one as well. So enteric coated we do not crush as well. And remember, enteric coated is the ones that help protect the stomach. The fourth one there, see the capsule, the first capsule with all the little beads. So no, we cannot open that up and crush those little beads because that's probably a sustained release medication or long-acting medication. Then there's a regular capsule. And then you see the pretty yellow gold shiny one. That one looks like medication that may have like a clear lining, but it has liquid medication inside of it. And you have to read specifically about those meds to see if you can crush those or put a hole in them and squirt the stuff out. For medicine, for people who may have trouble swallowing. This is an example of a pill splitter. On the left hand side, it's a blurry picture, I apologize for that. On the left hand side is a pill splitter, and you only are supposed to split medications who have a scored area, meaning that there's a line across the middle of the pill, and that's the only ones that should be scored. Then the other part of that is it crushes the medication, as you can see, the powdery solution there. And then we mix that with water to give to the patient. We don't give them that powder. That would be yucky. Okay, we also have pump delivery systems such as insulin is an example of that. And we also have medicines given by mouth, so tablets, capsules, sublingual, buccal. We have the enteric controlled release. We have the enteric coated, and the controlled release again maintains a more consistent serum drug level and less administration time, more convenient with the patient. These are tablets and capsules, and they contain a high amount of the drug, so that's why you don't want to crush them, because they'll get a whammy dose. It's intended to be absorbed slowly over a prolonged time of period. And then we have the transdermal, which is a systemic absorption through the skin. Again, the pump delivery system, that can be an external or implanted type of medication. And let's see, it can be very, very helpful for patients who, for instance, would be a diabetic. It can help with pain medication or anti-cancer medication. And this is an example of a pump, an insulin pump. Okay, and then we have our topical solutions. We got, solutions, creams, suppositories. You see the little silver bullet. Don't forget on suppositories that you must take the medicine out of the wrapper before you give it to the patient and insert it rectally. It works much better that way. Now these are examples of GI tubes, gastrointestinal tubes. So you see one coming from the nose there, and I don't know if this pointer is going to work, but I'll try it. There's the the nasogastric tube, and then this is type of TPN that's given, nutrition that's given through a vein. Let's see here. We have a nasojejunal tube that goes down to the jejunum, and then you see the tube, you see it right here, and then you see the gastrostomy tube as well. This is an inhaler, and this is a meter dosed inhaler, and so one squirt gives the patient a specific amount of dose of the inhaler. And this medication, the inhaler, is put on the end of it, and the patient puts their mouth here at the smaller end of it, and it just keeps that medicine in there so that the patient can inhale all of that medicine. Okay, calculating med doses, that's, obviously going to be extremely important, and knowing the units of measurement, utilizing what you've learned in Math 126. Don't forget your CDCE, your comprehensive drug calculation exam that will be given in your Nursing 105 course in the fall, around the first 2 weeks of that course. And we will have some calculation problems on our test in this course as well, because hey, we're in pharmacology. You got to expect that. This comes from your book, as it gives you a way of doing drug calculation, but whatever way you've learned, you stick with that way. This is selective equivalent measurements, and so these are obvious measurements that you need to know about. Okay, routes of administration, page 48, or on table 3-5, and nursing interventions, page 58 through 60. Think safety when we're talking about administration. You have some excellent textbook student resources on the point with your textbook, and there's watch and learn videos and concepts in action for just about every way to give medications. So be sure to take a look at that. Okay, question: which of the following is a parenteral route of medication administration? Applying medication directly to the skin, is that a perennial, or what is that called? So that's topical. Oral medication administration is oral medication administration. Instilling sterile eye drops, that's ophthalmic. And administering an intramuscular medication. Okay, and that is your perennial type. So IM injection, IV, and sub-Q, those are parenteral versus oral medications or installing sterile as eye drops, that's a topical type. Okay, medications for injection. We've got to have pre-packaged, prepared supplies and medication, and we've got to administer and maintain sterility of that equipment. And why is that? Because it's going beyond the top, the outer layer of our skin. It's going inside of the body, so we've got to maintain sterility when we're doing this. Typical medication containers, we have vials and ampules and pre-filled syringes with attached needles. And so these are an example. On the left hand side is an example of a vial, and you can see like that's an influenza, so it's a multi-dose vial. You would provide the date and your initials when you first open that up to start using. On the right hand side are ampules, and that's a single dose vial. So sterile needles of various gauges of the needles, and the larger number is actually a smaller lumen, and I don't know why they did it this way, but an 18 gauge needle is going to be a smaller lumen. Lumen meaning the channel of the catheter. There's various lengths, and we just used, it depends on where we're administering, what's the thickness of the solution, and what's the size of the patient. The needleless system, we have been fortunate to have that developed throughout the years to where we don't use as many needles as what we used to because needles are a source of bloodborne pathogens, and nurses get stuck with needles a lot. So, you know, we're glad about the needleless system. Syringes, they are made of plastic and calibrated to measure doses accurately, and we have an insulin or tuberculin syringe for smaller doses. So here's a picture of a syringe up at the top there. You can see the needle, and that if you're given an IM injection, intramuscular injection, you obviously got to use a real needle. And that needle is secured in, it locks into that syringe, and you can see the plunger tip is how we measure how much medications we give. The things that are at the bottom are what we use for pre-filled syringes, or what can be used for pre-filled syringes to administer them. These you can see the different sizes of needles there. See how big the one on the bottom is versus the top. So there's a difference that's going to be, and also the length of them as well. So injection sites, the intradermal It's right underneath the skin. The sub-Q is in our subcutaneous fat, and the upper arms, abdomen, back, and the thighs. IM is a common site. The common sites is the deltoid, the dorsal gluteal, the ventral gluteal, the vastus lateralis, and then of course IV common sites are the back of the hand or the forearm. And here's your angle at which different perineal medications are given. So IM injection is a 90-degree angle that we enter into the skin. Sub-Q is at a 45-degree angle. Sub-Q can actually be given 90-degree angle if you pull up on the skin. Intravenous is at a 25-degree angle because we're trying to hit that vein there. And intradermal is your 10 to 15-degree angle. And you can see on the right-hand side the different layers of the skin there. These are examples, and these are in your book as well, of places for sub-Q injections. And there's for IM injection. And you will practice this. You will practice this on mannequins, not on each other. And that's the side of the leg there. Here's your IV. Okay, and these are IV supplies that we use. You have at the top picture there on the left, you got gloves, of course, alcohol prep, and you've got a large volume fluid, and you got the tubing, and then you've got your connecting tubing that can be used there, and then you see on the right hand side where that all goes into the patient, so that you can see the tubing is spiked, and again all of this is sterile until you open it, and then once you open it, we've got to treat those tips and connectors and keep all that sterility as it's supposed to be. This particular tubing for this medication has a roller clamp where you can adjust how fast the fluid goes into the patient. And then this just shows you an example of starting an IV. You see the tourniquet there. The IV is put in, and she's putting a dressing on the patient. And then let's see, she looks like she is getting ready to flush the medication. And she's taking off that tourniquet too. Gotta not forget to take off the tourniquet. But again, you will get practice on this when in your Nursing 105 class. Here is a piggyback. Remember the IV piggyback? There's a smaller bag, and it is hung higher than the large volume fluid because gravity is going to let it go in. And it's connected with a Y site, injection site there. Okay, complications of IV therapy is going to be that the IV infiltrates, meaning it gets out of the vein and goes into the skin. Not good. Not good. So that's why we got to assess after we do an IV. Make sure that is in the right place, that the fluid, the IV is in the right place. Phlebitis, which is an infection of the area, can occur. So we definitely don't want that. Thrombus is where there can be a blood clot. And then extravasation is where very, very harmful medication goes into the skin and can cause serious, serious problems. So we always want to be sure we're in the vein before accessing an IV. And, you know, the way we do that is we're going to actually withdraw a little bit of fluid from the site down close to the needle, and if we see a blood return or a flashback of the blood, then that means we're in the vein. If we give medications and don't do this, I'll give you an example of what could happen. Now, this is not the best pictures in the world, but take a look at that little baby's hand on the right side. On the left side. And it's a foot on the right side. Either one. They're bad. Bad, 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 bad. This is where the cause of this is IVs not being in the right place at the right time. And the baby, I'm not sure if they ended up losing their hand or not on that, or the foot, but it's terrible. Okay, many times we use IV pumps, and this is an example of an older looking one, but you'll learn how to use these when you're given medications. Many medications will say that you need to use a pump with them because that controls the rate of volume, how much the medication they're getting. And, it's rare that you don't see pumps being used on patients, on all patients. So you'll become very familiar with pumps. Less common injection sites, intradermal, intra-arterial. The physicians must do the intra-articular, meaning into the joint, and intrathecal, meaning into the spinal fluid area. Okay, the nursing process is rarely used in drug therapy. So what do you think the answer to that is? I think you better say the answer is false, because we're going to do a lot of assessing and gathering information on patients to provide them care. So the nursing process, it is assessment. So take a look at your medication history on page 54 in your box there. That's a great medication history that we can get on patients. We're going to assess the prescriptions, what medicines the patient's currently on, and any newly ordered medicines, because that's reconciliation. We're going to assess the patient's knowledge regarding current medications. We are going to look at non-prescription meds that they're on, and do they use any social and herbal dietary meds? What's their allergy history? And can the patient swallow? Can they communicate? Can they follow directions? The nursing diagnosis, we can have knowledge deficit. We can have non-compliance. We can also have, risk for injury related to those adverse effects. Planning and goals, take a look at on your page 54 to talk about that. So we want to definitely improve their knowledge. We want them to be compliant. We want them to not have any kind of injuries. General non-drug interventions. We do these a lot, and it's really important. But promoting health, that's what we're all about. We're going to talk to them about preventing and decreasing need for drug therapy, if that is even a possibility. Using non-drug measures to influence therapeutic effects of whatever condition they're having. If there's evidence-based medicine and evidence-based information out there about that. Patient teaching is a huge thing that we got to do. So take a look at all of those boxes there. Individualizing care. Every patient reacts different. Every patient is different. So we got to individualize the care. Prior to MedAdmin, we've got to assess applicable items, whatever the medication is based on. Okay, whatever medicines they have, then we've got to do that baseline assessment or assessing prior to giving them, and then observing the patient's response. Promoting healthy lifestyles, nutrition, fluid, exercise, rest, sleep. consistently performing hand hygiene, infection prevention. Now that's a biggie, and that's important. Single most offense against infection is hand washing. Ambulating, positioning, exercising, assisting to cough and deep breathe, applying heat and cold, scheduling activities to promote rest and sleep. So these are different non-drug interventions that nurses use a lot. Instead of giving a pain medication, we might use heat for a certain problem, or application of cold for a certain problem. So medication administration related interventions, take a look at on page 58 through 60 to determine that. And as you study the medicines, you're going to learn specific interventions that you'll be doing with each of those as you give. Always remember to assess your patient, your lab work, and your orders to make sure that you are doing the right medication, following the 5 rights or the 10 rights as it is now. And don't forget, teach, teach, teach. We will be doing a lot of teaching. Evaluation criteria, we want to see if we've met that therapeutic approach or therapeutic effects of the medication, and we also need to evaluate our adverse effects. What's the patient's compliance? Are they taking their medicines? And, compliance can be a lot of different things, or non-compliance, I should say. If a patient is not taking their medicine, we need to find out why. And patients will tell nurses things that they many times won't tell their doctor. So, investigate. Why aren't you taking, or first off, are you taking the medication as ordered? And if they say no, we want to say, well, why not? And, it could be lots of different things. It could be that they can't afford it. It could be that the side effects they don't like, they're having and experiencing. So we've got to investigate that kind of thing. Evidence-based practice is what we're all about, and that's what we're given. We take care of patients with evidence-based care, and that's obtained by utilizing your textbook and the different things that we have talked about, because that's the safest care. It's all about safety, folks. Okay, herbal and dietary supplements, definitely need to ask the patient about that. Many times they don't consider those as being parts of medications, but we definitely need to know about it, because these medicines are not controlled by the FDA and those DEA and those people, all of those rigorous laws that the medicines that are prescribed out there go through. Herbs do not. And so, they can be very dangerous, especially when they're mixed with certain drugs. And just the other day, had a friend, we were talking about one of the herbal medicines. She had started on the Black Koch, I guess that's how you say it, and it's used for like menopause effects. And she's, one of these healthy people. She runs all the time and eats healthy and, lives a healthy lifestyle. And anyway, she went to a doctor for her checkup, and her lab values for her liver enzymes had elevated to over 1,000, and the normal values are in the hundreds there, like 150. And so, anyway, come to find out, it was because she had been on this medication, is what the suspect was about. So, anyway, we need to know about those medications and what they're taking with regards to this. And we have to many times ask, what about supplements? Because they will not even They will not even consider them as medications many times. Okay, I know this has been long, but it is a big chapter, and this concludes your podcast.